Hi, I'm Roger Michaud. At Franklin Templeton Investments, we believe that citizens need to be informed about the resources that can help make higher education more affordable. That's why we're proud to support programming produced by the CAUCUS Educational Corporation and their partners in public television.
Cardiovascular breakthroughs next on CAUCUS New Jersey.
Funding for this edition of CAUCUS New Jersey has been provided by Celgene Corporation, committed to improving the lives of patients worldwide. The Healthcare Foundation of New Jersey, founded by the Jewish community. MD Advantage Insurance Company of New Jersey. Investors Bank. Berkeley College. Health Republic Insurance of New Jersey. And by New Jersey Natural Gas, proud to support education in our communities. Promotional support provided by Commerce Magazine and by The Record, North Jersey's trusted source, and northjersey.com.
Welcome to CAUCUS New Jersey. I'm Steve Adubato. You know, long wait times and decreased availability of donors has led doctors to seek new methods to support a failing heart. Here to discuss something called Ventricular Assist Device, or VADs, we have Joseph Shukis, is a patient living with a Ventricular Assist Device, or VAD. Dr. George Batsides, who is a chief of cardiac surgery at RWJ University Hospital. Audrey Kleet is a VAD coordinator at Morristown Medical Center. And finally, Sharon Holman is a senior occupational therapist at Kessler Institute for Rehabilitation. I want to thank all of you for joining us. This is interesting, other than the fact that ventricular assist device is a hard thing to say, doctor. It is huge, important, and groundbreaking, no?
Yes, absolutely. These devices are mechanical circulatory support systems that help support patients with failing hearts. You know, in the United States, I think there's about 2,000 transplants done a year.
2,000? 2,000
a year, 2,200 roughly. Worldwide, it's about 5,000. So there's probably about 100,000 patients in the U.S. alone that could benefit from a device like this. Part of it is getting the word out. These patients have failing hearts for a multitude of reasons, whether it's MIs, heart attacks, whether it's idiopathic, or we don't know the cause, or viruses. These patients present in what we call class 3 or class 4 heart failure. Like Mr. Shukis, he said he was kind of living his life, canoeing or kayaking and riding his bike, and then he would get into these coughing fits and spells where he couldn't breathe. And over, I guess, about the next year, he started having shortness of breath more and more frequently. He was admitted for CHF, congestive heart failure. When you get to that situation and we do an ultrasound of the heart and see that the heart is failing, the function's down, less than 30% or so, medications work to some degree. But after that, either the patient can get listed for a transplant where they truly have a failing heart, or we can implant one of these devices to support the circulation.
So Joe, it's interesting. Joe, you're 76 years of age, right? In fact, you look 77. Yeah. Oh, well, you look fabulous. You had a heart attack.
Yes, 2012.
You're working out. You're taking care of yourself. You're doing all the right things.
Yeah.
Traditional, let's just say, other than the VAD, the ventricular assist device before that, it wasn't happening for you. You weren't getting the relief that you needed. You weren't getting the help you needed. How do you make the decision, yes, I'm going with this. I'm going to have this device. And if I can do this, I know we have some video team, but doctor, can you just let me have that? I'm going to hold this up. And as we talk about this, as we come in, Bob Morris, our director, as you shoot this is inside you right now.
Yes, it is.
The decision was made by you and your family, along with your medical team,
yes,
to go with it.
Yes.
Why?
Well, I did some tests at Robert Wood Johnson on me. I think it was a SWAN test. Mm-hmm. And one side of my heart was able to take that. Both sides of my heart, I guess,
were failing.
Were failing.
Right.
And I thought, well, what is my alternative?
What was it?
I wouldn't be here today if Dr. Batsides.
You pretty confident of that?
Absolutely.
Is he right?
Yeah, yeah. Most of these patients, when they get to the point where they're hospitalized for recurrent bouts of CHF, when they have
CHF, congestive heart failure.
when they have this weakened heart state, again, from heart attack, sometimes we see patients with viral myocarditis. There's a host of things that can cause it. In his case, it was prior MI, prior heart attack.
Myocardial
infarction.
Right.
So once they have that and they come in, there are some medicines, we call them inotropes, that can help the heart squeeze. And we can send patients home, and I believe we started him on some,
Yes.
and they do help for some time, but it's limited. We can go up on the dosing. Eventually, they can't help anymore.
But quality of life, I mean, here's the thing, and we're about to show some video here. You were taking care of yourself, doing all the right things, but you couldn't do the things, I understand this, you told our producers you couldn't do the things that you wanted to do, okay? Now today, you have this in you right now.
Yes.
What are you able to do today?
I'm able to do everything except bike. That's the only thing I can do at this point.
And kayaking,
And kayaking.
which you had done before.
I have to stay out of the water.
Okay,
Yeah.
we'll talk about why the water in a moment.
Okay. Yeah.
Do you walk a lot?
Yes, I do. You know, weather permitting.
You drive, you shop, you live your
I
life.
cook.
You cook.
Yeah, I love to cook.
Before that, how much of that could you do?
I could do a lot up until I was about 70, I would say. 69, 70 years of age.
And you're a cyclist.
Yeah, I put a lot of miles on. A lot of miles. Thousands of miles.
Paula, Levine, our producer, are we ready to show that video? Why don't we take a look at the video that really brings us to life? We'll come back and talk about it a little bit more. Talk this through, doctor, for us.
So this is a picture of the HeartMate 2. It's an implantable left ventricular assist device. We sew the device to the apex of the left ventricle. And we sew it to the apex of the left ventricle, and it is inserted. There's a little cannula that gets inserted to the apex. And the device, inside the device is basically an impeller or a fancy screw that drives this. It sucks the blood through the left ventricle and propels it to the aorta. You see that graft sewn to the large artery that leaves the heart. The blood will then go to the aorta and feed the rest of the body, all the organ systems.
So it's under the, okay, now I want to bring the two of you in here. This has got to be, I'm thinking this through. Now for Joe, okay, improve the quality of his life. But aren't there other people involved that have to be helpful to whether it's Joe or anyone else who's living with a VAD, right? Jump in.
When Joe was first identified by his medical team, he had to meet a group of multidisciplinary practitioners, so surgeons and cardiologists and nurses, nurse practitioners, therapists, physical therapists, occupational therapists, nutritionists. So he had to meet a whole team of people.
And that's why you're a VAD coordinator?
Correct.
Which I didn't think that title existed, but go ahead.
It absolutely
But it needs to exist.
It needs to exist.
Talk about it.
To support the patient and the caregiver along the continuum of their care from the time that they're first identified for this particular
For
therapy.
example, give a concrete example as to what has to be coordinated.
For example, when Joe and his caregiver were first considering this therapy, they needed to understand more about living with the therapy, and Joe specifically what he would need to do for himself every day, and his caregiver what he or she may need to do to help him every day with this therapy. So an intense amount of teaching needed to be done to help him and his caregiver realize
this. He's
this.
attached to this device.
He's attached to this device for the rest of his life. And that being said, it's more than just a bunch of pills every day. He needs to take care of a piece of wire that comes out of his skin called a drive line to make sure that that is kept intact and able to support the device inside of him that's helping him to live.
So let me try this. Joe, without being too intrusive,
Yes.
I met your wife on the way in here. She
Yes.
was very vocal. She was telling me she's your biggest fan.
Yes.
You know, she is. She'll give you a review on your performance after the show. I'm sure she'll give me a review of mine as well.
Yeah.
Is it too intrusive if I asked you to open up the left side? Can we get this, guys, on camera?
Absolutely.
This
As the controller.
That's the controller.
Yeah.
So this controller is actually the brains of the operation. There's 2 computers inside this particular controller that drive the device inside, tell it what to do. And the only way this computer knows what to do is through a device that we have in the hospital, and we set it up initially in the operating room along with the surgeon, and then tweak the device over time throughout the patient's initial recovery and then through the continuum of their care.
He has to have this attached to him for the rest of his life.
Has to have this for the rest of his
Is
life.
Joe controlling this?
Joe is not controlling this. This little controller is controlling the device inside of him. It's set up by his healthcare team.
And where are the batteries?
Probably under his arms.
Yeah.
Whoa.
So
Does this ever bother
There's
you?
another one on the other. No.
Does not
It's-
bother you?
the weight bothers me a little bit. I'm not
little bit
used
heavier than
to-
normal.
Yeah, I'm not used to the weight at this point. So I'm still caning it a little bit.
Jump in.
As an occupational therapist, I
Yeah,
absolutely...
explain your role here at Kessler
So
Institute.
I'm an occupational therapist. As occupational therapy, we look at anything and everything that you have to do every day. So you could see that's a wide variety, and it differs depending on the individual. But we look at basic activities of daily living. So things from getting dressed and taking a shower, all the way to more complex tasks like engaging in leisure activities or skills needed to return to work. So for somebody who's come to us with a VAD, what we would look at is initially, that education and functional endurance, being able to participate in those daily tasks while managing the components that Joe just showed you, those various components of the LVAD. One of the things that's very difficult at first, and that takes a lot of training for individuals who have just had this, is being able to take a shower, because like we just saw, that's attached to him. There's batteries. Those
How
cannot
does
get
it?
wet. So there was at one point, I believe there still is, like a waterproof briefcase, if you will.
Yes,
So you
it's
have
like a
to,
little briefcase.
yeah. So we do a lot of training on that, and you have to be able to have the dexterity to take the batteries out, put them in that briefcase, be able to zip everything up and put the
Yes.
lines where
Do you
they're
do it
supposed
alone?
to
Your
be.
wife help you?
My wife helps me a little bit.
Not
What?
enough.
No, enough.
I just want to
Yeah.
make sure, because, are you complaining about that?
No, not
just
really.
wanna make sure.
The only thing I complain about is the weight of the batteries. That's the only
That's the thing. How much? You keep saying that, Joe. How much do they weigh?
A couple pounds.
Couple
It's like,
pounds.
Yeah.
and trying to walk in that snow and the ice out there.
Oh yeah, we're doing the show in the winter.
You know what I mean?
That's not
It's,
easy.
what a
It's,
pain.
it's not easy for the rest of us. It must be harder for you, right?
It is a little bit harder.
But the shower is an issue.
It's not that bad. I thought it was going to be worse than it
Okay.
is. But the bag fits up on a rack
Okay.
where the shampoo and everything else goes, and the wires come out and they can get wet. In other words,
And what happens if they get wet? Doc, what happens if they get wet?
Nothing happens as long as the batteries and the controller don't get wet.
You're smiling. Why are you smiling?
The wires can get wet.
Yes.
The issue is getting the site where the driveline
Right,
exits the
right.
body, that
Yeah.
wire that communicates with the device inside. The issue is getting that wet.
Jump back
That's
in,
a little
Doc.
bit of the Achilles heel to the whole device here. That area, if there's trauma to it, if it gets pulled a lot, we've had very active patients that they really pull on that because they're doing their daily activities and they're moving around and they don't pay attention to it after a while. If that gets pulled a lot and there's trauma, they can get infected. I think that's the big issue. We've been very fortunate in our program to not have too many infections in that area, but that's the one thing.
I'm very careful about that.
Yeah.
So let me ask you something. How fortunate do you feel that you have had this opportunity? I don't want to say it a second life, but you said it. How fortunate do you feel?
Very.
What would you say to folks, Joe, who say, hey, listen, I'm not sure who's a candidate clinically or not, doctor, that's your world. But someone who has said, listen, I've tried everything, and we're not here to promote, because again, I don't know who is and who's not. But had you, and if you don't want to talk about this, Joe, I understand, had you almost given up?
Not quite.
Close?
Yeah.
Yeah. Do you see that a lot, doctor?
Yeah, absolutely. It's a trade-off, and I'm just going from patient experiences. They tell me that their quality of life is good with these. It's a trade-off. They have a device, they have the drive line, the batteries.
Trade-off.
Trade-off for where they were before. But most of the patients, if not all, that we've put this device in, they're very happy they made that decision.
How many?
At our program, we place about 15 a year. We have short-term devices and intermediate length devices and these long-term implantable devices.
Oh, explain that again. 3 different VADs?
Yes.
For 3 different types of patients
Absolutely.
with 3 different types of prognosis situations? What?
Absolutely. So the way I break it down, the short-term VAD is for the patient that comes in full-blown cardiogenic shock from, say, a massive heart attack.
Okay.
Those patients are in shock. They're hypoperfused, low flow state.
Come on, what's that? You know.
Low flow state to their brain, to their kidneys, to all their organ systems.
Got it.
Because the heart's not pumping properly. So in those patients, we currently use 3 separate devices at our institution, depending on the patient's scenario, and implant them as quickly as we can. Those devices are used as a bridge. Basically a bridge to decision is what I like to think. We implant them, we see how the patient does, do they recover, and what's the next step.
Does it buy you time?
Absolutely, it buys the patient time. And those patients, sometimes then we will explant them because their heart just needs a few weeks to rest. Whether it's they get a stent to open up the coronary, or we do some bypasses for the coronary, or we fix the valve. Sometimes this is due to valve pathology. Once we understand where we're going with the patient, we can explant them, we can transition them
Explant means
take them out, and they go on their way. We can take them, list them for a transplant potentially in the acute setting if they're recovered fully and we think they can tolerate a transplant. They don't have many options. You know, Joe's case here, his right heart has to work for this device to work. Some patients, their right heart doesn't work because of the shock state.
And what happens if that was the case?
So then that's the case. They stay in the hospital with the intermediate length VADs where they can live a few months. And they ambulate, they walk through the hospital, they sit outside their body, these devices, and it buys them time to get their transplant.
Got it. But Joe has a destination.
Right, so that's the big
VAD.
difference. So
It's there, that's it.
That's it, and that's where we are at this point in ventricular assist therapy. We have VADs patients where we transition them to we call them this destination VADs where they get their machine placed, and that's the remaining years of their life.
How long will this VAD last?
So we currently have about, I think, 15 patients out in the community with destination VADs. Our longest running is 4 years. The company has about, I think, about 16 or 17,000 VADs implanted worldwide.
Wow.
And their longest patient now is a little over 8 years.
Got it.
So they can last.
And the technology continues to change. Let me ask you this. Let me talk about the preparation. I want you both to jump in because you're on the preparation and you're on the rehab.
Getting them back home.
Okay. How do you actually prepare a patient and his or her family for what they're about to face when in fact they don't really know what that is until they actually face it?
One of the most helpful preparation options that we utilize at our center is to pair a like patient and caregiver with a patient who is living on an LVAD. So
say someone talked to Joe.
Right.
Could he be helpful in that process?
Oh, without a doubt.
Talk
without
about
a doubt. To go and talk to a patient and their caregiver that's considering this type of therapy. There are options, as Dr. Batsides was laying out for patients, even if that option is just comfort care, something we call palliative care, to be on just medicines for the rest of their life. They do not necessarily need to choose a surgical option in getting the ventricular assist device. So one of the things we like to do to help them make an informed decision about this is to bring another patient in who's been living on their VAD and just facilitate a discussion between those two patients without any of us medical professionals in the room. That way they can be open and honest and really understand what is this all about.
That must be very powerful to answer a lot of questions and relieve some of the anxiety, because the anxiety often comes from the unknown, I imagine, even though everyone's experience is different. On the other end, once it happens, go ahead.
Once it happens, so the patient would typically come to, if they're not going home directly from the hospital, they would come to an inpatient rehab setting, and it's really an interdisciplinary approach. Like we were speaking about before, we work together with the patient and their family, with everybody.
Describe Kessler. We have a relationship with the Kessler Foundation.
Okay, yes.
Which is tied to the Institute, but describe it.
It's an inpatient rehabilitation setting where a lot of patients come. We have a variety of different types of patients that come, but we do have a cardiac program. We accept LVAD patients. Then we have a stroke program, brain injury program, all those.
Got it. But is there something unique about, I guess there's something unique about every patient dealing with whatever he or she is dealing with. But I'm thinking about, you keep calling it LVAD. By the way, why is it not a VAD and an LVAD? Is that two different things?
It's just a habit. It's the left
It's a
ventricle.
left ventricular
Yeah,
device,
I
you
just,
know.
that's my
Okay,
habit.
so the VAD, right?
Yes.
The
yeah.
ventricular assist device. Is there something unique about the rehab process that those patients go through that we need to better understand?
I just think it's very unique in that it's a life-changing operation. You know, you have to be, the patient that has to be going home dealing with this piece of equipment. So it takes a lot of education in different disciplines. So nursing, from nursing to all the different therapies to nutrition and working on your diets with the
Why does that
cardiac
matter?
history to
Why does
remain
diet
healthy,
matter?
to remain healthy and keep an appropriate
Really?
diet as you continue with your
But does he have,
VAD.
excuse me for interrupting,
So-
certain restrictions?
Well, I tell all my patients, and he may recall, that after surgery, I give them the first month, eat whatever you want. And that's the only time a doctor...
1 month, right,
For
Doc?
1 month, 1 to 2 months. My point with that is just get some protein, some nourishment into their body to heal their wounds. So they need to just take in calories. At that, barring if you have some diabetic issues, you want to watch your sugars, but really just take in calories, some protein to supplement them so they can heal. At that point, moving forward, it's up to the patient. I think everyone knows what a heart-healthy diet is to some degree. I don't give them too many restrictions with this. I said, go out and live your life. Go enjoy your life. But you want to do it with moderation too. Really.
It's important to remember that these are patients who are chronically living with heart failure. They're in a chronic state of heart failure. So the C in congestive heart failure, it's not just for congestive, it's also for chronic.
Time out. Joe's not fixed.
Joe's not fixed. This
He's
is a
what? But
therapy
he's-
to treat his heart failure.
Hold on, but I'm looking at him, and I'm thinking, looks great, presents really well. He looks like he's in great shape physically, but what?
But his heart is not fixed, as you said. This is a therapy to help him. It's when medicines fail, this is a surgical therapy that we have to help Joe and patients like him.
How do you see yourself?
75 to 80% of what I was.
And you were?
I was up there. As far as
Percent-wise, if you feel 75 to 80% of what you were,
it's a hard thing to say. I mean, it's all subjective.
you were nowhere near that.
No.
Okay.
I lost a lot, and I lost a lot of weight.
Oh, you did?
Yeah, I lost my taste for food. I couldn't taste coffee.
What?
Could not taste it. It tasted like dishwater to me.
You have any idea why?
I have no idea why. A doctor could.
Leading up to it, not post-surgery, right? Just leading up to it. It's the
Yes.
heart failure. I mean, we call it cardiac cachexia. These patients just
Cardiac
cachexia.
cachexia?
They just kind of waste.
I lost 70 pounds.
70?
70 pounds, yeah. I went from 220 to 150.
What's your weight at now? Because you're not 220 now.
188.
I was going to say, yeah.
Yeah.
Do you like your weight where it is right now?
Yes.
And you're
I'm just about where I want to be.
and you manage your diet well.
Oh, yeah.
And going back to the family issue again, I'm curious about this because it does require family involvement. If a patient, Joe does have his wife, and there are other family members involved?
No, just my wife and I.
Okay. If someone
kids
doesn't-
are all gone.
Sorry.
They're elsewhere.
Okay. If someone does not have a caregiver, someone who's directly involved, how much more challenging is that?
A lot more challenging.
It is, yes.
Because part of the VAD coordinator's role is to manage these patients along with the rest of the team over the time period from when they're initially identified throughout their life on the device. It makes them a much more riskier situation that they don't have somebody regularly to rely on outside the hospital.
Go ahead.
I was going to say we did have an individual who was on his own, so we were doing so much education, so much training, making sure he could, change the batteries, take them out, let them charge overnight while he was sleeping, and make sure that he was fully independent. And there was actually an instance during one of the hurricanes where we were out of power temporarily at night, in the middle of the night, and in that time before the generators kicked on, he had, tremendous amount of fear, but then his instincts kicked in and he was able to switch himself, in essence, back to battery power in the middle of the night in the darkness before the generators kicked back on. And although that was a very, very scary event for him, it kind of gave him a sense of that control back. Like, I got this, I could do this, even if I was at home just now by myself, I had the instincts, and you guys have given me the training to be able to do it.
A few seconds left. Reason to be hopeful.
Reason to be hopeful. This device has saved many lives, and it's giving them a good quality of life. And these patients with failing hearts, the future is very bright with these devices. The next generation's right around the corner. They're even smaller. Hopefully, we'll get to the point, and I think it's very soon, that we'll have a totally implantable device with cutaneous charging systems.
Appreciate all of you being here. I'm with you nothing but the best, Joe. Thank you very much.
The preceding program has been a production of the CAUCUS Educational Corporation, celebrating 25 years of broadcast excellence, and 13 for WNET, NJTV, and WHYY. Funding for this edition of CAUCUS New Jersey has been provided by Celgene Corporation, the Healthcare Foundation of New Jersey, MD Advantage Insurance Company of New Jersey, Investors Bank, Berkeley College, Health Republic Insurance of New Jersey, and by New Jersey Natural Gas. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area. CAUCUS New Jersey has been produced in partnership with TriStar Studios.
This healthcare message is brought to you by MD Advantage Insurance Company of New Jersey.
Choosing a new family doctor can be confusing. Check with your health insurer to see which physicians near you participate with your plan. Find out which hospitals the doctor uses and who covers when the doctor is away. And remember to schedule an appointment with your new doctor in advance to fill out any paperwork without the added stress of being sick.